Am I recording?
No.
Doesn't look like it. Let's go in there again. Pause recording.
No,
Oh, no, it's recording. Okay. Tor, can you just or anyone else, can you just put a question to me to say that you can hear me? Or any other participant? Yep, excellent, thanks, thank you. All right, we might as well get started. So this is going to be a very quick one. As everybody's probably realised, there were two cases that were active in Western Australia. As of yesterday, there's 4 more that have just been diagnosed off a flight from Doha, I think. So we've got 6 active cases in Western Australia. Still, we have a very, very, very low prevalence, and we've got no known community transmission. We still haven't had any surprise cases admitted to any of the hospitals around Perth that haven't got strong epidemiological risk factors, i.e. travel, cruise ships, contact of positive patients and the like. So we're still in a very good position. The borders are still closed. All of the movement of people from overseas or interstate is strictly controlled. So Western Australia is in a good state. There's nothing really novel or new to add to the management of COVID-19. So we thought that we'd just do a Q&A session about stuff that people have. So I've got a list of questions that I'm going to go through. I can't work out. There you go. These questions are not the original questions. I've heavily edited most of them to be a bit more straightforward and simple and concise. So if a vaccine for COVID-19 becomes available, would serology be required prior to vaccination? So this is a very, very good question. And the person that asked it was sort of using rubella serology as an example. So the answer is we don't really know, because we don't actually know a lot yet still about the immunity to this virus. We do know that there's immunoglobulins that are formed in people that get infection against the nuclear capsid antigen, as well as the spike antigen, as well as other antigens as well. But those are the 2 main ones. And when you put these antibodies into viral culture media or into a cell line and then try to infect the cell line with viruses, we know that at a certain level in vitro, these antibodies neutralize the virus. But that's in vitro. We still don't know what happens in vivo in the human in real life. But at least the basic science looks promising. But the question about needing serology or not is uncertain. It really depends on working out what the total immunoglobulin amount required per mil of blood or serum to give someone immunity. We don't even know yet whether immunity is persistent or long-lasting. So the jury's still out, and every single different vaccine and serology test is also different. So, for instance, pertussis, the serology tests that are available, they're not actually useful to tell you whether you're immune or not. They can go up with exposure to virus or vaccination, but it doesn't necessarily convey immunity. You need to do quite specific immunity testing and specific serology that's not easy to do in most labs. Rubella, as an example, so we know that you have to have a certain quantitated amount of antibody detected before someone's considered immune. And the person that asked the question was saying things about, well, if you're detected, then you don't need another vaccine. Got to keep in mind that sometimes vaccines have multiple components to them. And in rubella's case, I don't believe in Australia you can get a rubella only vaccine. So measles, mumps and rubella is the standard vaccine, and everybody needs 2 doses of measles, mumps and rubella to be considered immune to measles. So everybody should have 2 doses, and you don't check their serology. But at the time that you become pregnant, or as part of your sort of prenatal screening, you get your rubella serology checked, because that's what's in the guidelines, and if it's low, then they recommend vaccination, etc. So everything's a bit different, and time will tell. So kind of a long-winded way of saying we don't know yet. Next one, can airvo or high-flow oxygen be used on non-COVID patients? And has there been any communication or recommendation regarding the use of airvo with non-COVID patients? So high-flow oxygen is in the West Australian PPE mandatory guidelines considered an aerosol generating procedure. So once you consider this an aerosol generating procedure, everything's relatively straightforward after that. So the next question that we have to ask, is the person a suspect or proven COVID patient? And if the answer is yes, then they need to be on airborne precautions and contact precautions. So goggles, gloves, long sleeve gown and an N95 mask. If the patient is no longer a suspect COVID patient, or they've had a test that said that they're negative, and they've been deemed to be non-COVID, the current guidelines suggest that we still use droplet precautions. There's nothing to say that this can't be used, but droplet precautions means that it has to be used in a single room still. So hopefully that answers your question. And I guess the other thing that needs to be dealt with regards to this question is, can you just use Evo on someone if you think that they don't have COVID? And I'd probably ask the question, if someone's got respiratory symptoms or oxygenation requirements that are acute and enough to justify high flow nasal prongs oxygen, you probably need to consider them a suspected COVID case unless you've got a better alternative diagnosis. So, but at the end of the day, even if you do decide that they have an alternative diagnosis, the current recommendations are that they get high flow nasal prong oxygen in droplet precautions in a single room. And if there are proven or suspect ones, ideally you do them in a negative pressure room, and that's what the guidelines say. Single room potentially, but not recommended, and would only happen if you didn't have a negative pressure room available to you. Is this next question's a bit tricky. So is a swallow assessment an AGP? What precautions do you need for asymptomatic patients, and what precautions do you need for suspected or proven positive patients? Is a swallowing assessment an aerosol generating procedure? So my personal opinion is that no, it's not. I don't see it as being significantly different to performing a swab, like a deep nasopharyngeal swab, where someone's likely to cough or gag. However, the Speech Therapists College or Association, I was reading their guidelines last night, based on particle studies, so not based on any infection control literature. Their college has come out and said that this is definitely an aerosol generating procedure. Their college statement also says that they've deemed it to be an aerosol generating procedure as a result of coughing. So the West Australian Health Department doesn't consider coughing to be an indication for airborne precautions. In fact, that's in most recent guidelines, both in the PPE document, but also in the management of COVID-19 in the healthcare setting document, and it's also in the National Infection Control PPE guidelines as well. But it's hard for me to say which is right and which is wrong. The reality being that I think that at the end of the day, it's not unreasonable in many situations for people performing, if we consider it an aerosol generating procedure and someone's got no symptoms, then there are lots of guidelines that do suggest using droplet precautions. And certainly if someone's asymptomatic and has no epidemiological risk factors for COVID-19 and someone needs a swallowing assessment, then I don't believe they need airborne precautions. In fact, I would not recommend it. But it's not unreasonable to have droplet precautions with a surgical mask. And in the current guidelines, you can have a short sleeve gown or apron and gloves. I mean, that's not unreasonable. If someone's suspected or proven positive to COVID-19 because of the lack of certainty around what is and isn't an aerosol generating procedure, I feel that it's not unreasonable until there's a directive to say it's not for airborne precautions to be used. But then you've got to ask the question, does the swallow assessment necessarily need to be done before the swab comes back if it's a suspected patient? And if it can wait, I would recommend doing that. So hopefully that's answered our question. I think these questions come from somebody else saying, is there a different level of protection when we do similar things? And unfortunately, there is a lot of inconsistency at the moment because we've been unable to, a lot of colleges and professional societies have operated in the void of the lack of government health department policies, which are starting to come out now. And so you'll see a lot of consolidation of everything and recommendations. I'm sitting on the PBE committee and I'm probably going to directly take this to that to make a statement in the next iteration of the guideline about aerosol swallowing assessment and what we determine it to be, because this has caused a lot of questions to come up. Hopefully I've answered the question a little bit. What's the process when a patient dies with COVID swabs still pending? This is a really good question. I haven't really thought about it, and I had to ask Alison in infection control, and I also know Mary McConnell has had a lot to do with this particular planning because I tend to look after and give advice about alive people. Anyway, the procedure is that if someone dies and they're suspected, then they should have a surgical mask placed on them almost immediately. And then the body needs to be handled with droplet precautions. So the staff members, healthcare workers that are handling the body need to wear surgical masks, gloves, long sleeve gowns, etc. And then the body needs to be placed in a leak-proof body bag according to the local guidelines. And at that point, that's about all I know. All of the rest of the regulations about where they go, how they get there, would probably need to be directed to the mortuary and the state mortuary. But from a ward perspective, that's probably all I can comment on procedures. If there's any further questions about this and what to do with the patient and etc., I'd probably get in contact with either Mary or Tara in infection control, Mary McConnell, the disaster coordinator, because they know a lot more about what happens after the patient leaves the ward than I do. So the next question. With so few COVID-19 cases in WA, is there a risk that we will become more vulnerable to a second wave since there is no community immunity? And can you explain herd immunity? My opinion, which is my opinion and is based on not particularly any science or anything, but the reality is that nobody that uses science really necessarily knows what's going to happen from now on as well. The reality is that our biggest risk is complacency and a lack of preparedness as a result of minimal exposure to this virus. So our hospital systems are all appropriately, because we can't justify it any longer, but we're appropriately unraveling components of our COVID-19 preparedness strategies. Because we don't have any COVID-19, it's very hard to justify keeping specialised units open to the highly staffed, but then have them sitting there on their hands not seeing any patients. So that's the one threat and we're still very prepared, and we've got lots of plans that can be immediately enacted in Joondalup, and I'll talk about that later. But that's probably our biggest risk in our state. Immunity-wise, so I'm going to link in the herd immunity concept. So herd immunity concept, I don't like that term because it equates human beings to livestock. This is a term that's come from agriculture. Basically, when you talk about herd immunity, you're implying that whatever organism you're talking about is almost a commodity and you'll expect losses. And I find it to be an offensive term generally. When we're talking about COVID-19, the reality is that even if you look at America, where they've got widespread community transmission, their population still only has about a couple of % of their entire population is infected. And they've got 300,000 plus deaths or something like that. Any herd immunity, when we talk about it, if we use vaccinations as an example, you need to basically have 90% of your population plus, or 95 really, of your population immune to measles to benefit from basically a collective immunity, which then means that your population can't have transmission of the virus because you're protected by all of the immune individuals. So if you consider that as the worst case example of how much immunity you need, if we had 90% of the population of the world immune through natural infection, then you've also got to factor in that roughly 1 to 2% of that 90%, so 5 billion, 6 billion people or whatever it is. So you'd have to have 1 to 2% of those people die, and that's an astronomical number. We're talking millions and millions of people dying around the world, hundreds of millions of people, which is completely unacceptable. And if we do end up with no vaccine, and if we do end up with an endemic infection over time, we will probably develop some sort of immune population, but it would come at great loss to the world population and mortality. The other thing that needs to be thought about, though, is natural selection, which is also a horrible concept to think about in the context of a viral infection. But over time, the people that are the most susceptible to this virus are going to die if it's left uncontrolled. And the remaining population will either be immune or their innate immune system has mechanisms by which they have mild illness or whatever. So, I mean, 80% of the population seems to not be fazed by this virus. So those will essentially be the people that have the selective advantage. So you've got immunity, you've got natural selection, and you've also got the concept with the virus of natural selection as well. Viruses are promiscuous little particles of nucleic acid that basically all they want to do is replicate and share their genetic material, and they don't care how they do it. But natural selection operates every day with these viruses. There's no interest, and I don't mean to anthropomorphize a virus, but the virus has no interest in killing its host. In fact, it would like to keep its host alive as long as physically possible, with the longest period of transmissibility possible to be able to spread itself far and wide. And any virus that has a high mortality is likely to die out because the host will pass away before there's a chance to spread the infection. And that's probably the unique thing about this virus, is that it's highly transmissible in people that are not unwell, but it tends to cause death later on in the illness after there's plenty of time for it to transmit. However, the virus will likely evolve over time to be less virulent and to have less effect. In conjunction, the human race will as well. So hopefully I've, again, in a long-winded way, answered the question. So this was a very, very long question, and I've really sort of made it a lot more succinct. And this is from a doctor that's obviously been trained in the National Health Service, the NHS. What is a sufficient alternative diagnosis when looking at the current suspected case definition for testing? What is your opinion regarding swabbing X-ray confirmed pneumonias, consolidations being admitted? And what about patients who don't fit the suspect case definition? So the first question, listen, this is actually a really hard question to answer because obviously it's all up to the individual clinician, their confidence, their experience, and the time that they have to make a decision. And in certain circumstances in medicine, say in emergency, there is not the same amount of time to make decisions, and there's not the same amount of information available when you've got an undifferentiated patient in front of you. So it really depends on your scenario and your circumstance. And at the end of the day, we will over-test and we will inappropriately test people that quite clearly have an alternative diagnosis. And I fully expect that. And like every screening test, and particularly at the moment, yeah, none of the patients that we're screening, none of them have COVID-19. But if just one of them comes through, slips through and ends up on the ward, we will have a small disaster on our hands if they're not on appropriate precautions. So it is a fine balance between common sense and over testing, but not under testing, and it's quite difficult to get the balance right. And I'd rather overdo it than underdo it and risk missing a case. The reality is, from my perspective, an alternative diagnosis is quite a clear, obvious alternative that's got nothing to do with the respiratory tract. So urinary tract infections that are proven with a urinalysis and someone with symptoms, I mean, that's pretty reasonable. If they've got, and there's lots of, this is an annoying virus that has many very different ways of presenting, but at the moment we've got such a low prevalence that even if someone meets the criteria and gets through the hospital without being tested, the reality is it's unlikely that it's going to cause a problem. But it doesn't mean we shouldn't aim to catch these patients. If they've got abdominal pain, if they've quite clearly got other infective processes going on, like cellulitis or a wound infection, if they've had a stroke or something, if they've had a seizure, and they've got a fever immediately after the seizure, all those sorts of things are reasonable alternative diagnoses. It's a little bit more unclear when you get into the respiratory tract. I would completely support people wanting to swab people early in their presentation with symptoms consistent with pneumonia or even mild consolidation on their chest X-ray. This virus presents with viral pneumonia, and despite early on in the piece having one of the testing criteria being severe bilateral pneumonia probably starts looking like a unilateral pneumonia at some stage. So, I mean, I wouldn't be caught up in trying to sort of not swab patients because they've got a unilateral pneumonia. And the question actually mentioned bacterial pneumonia versus other, and aspiration as well. I mean, the reality is that it's difficult to confirm a bacterial pneumonia diagnosis apart from having the benefit of time and a response to antibiotics and multiple other tests probably CT scans, which I certainly don't recommend for everyone coming into hospital with query community-acquired pneumonia. But it's hard to tease them apart. And I mean, aspiration pneumonia, so often we just decide that patients have aspiration pneumonia because they said they had a coughing fit or something like that, and we convince ourselves that there's right lower zone changes, and ordinarily that's perfectly reasonable. I've done that before as well. But unless someone's had quite a clear aspiration event where they obviously had food, aspirated food or liquid or something like that, and had quite clear changes in the right lower mid-zone consistent with an aspiration, then I mean, you wouldn't, based on a funny history, just say, oh, it's an aspiration pneumonia, they don't need a swab. And the reality is that all of the people that we're testing at the moment, they don't have COVID-19, but there could be one that does. And we're wasting a lot of resources on this, and there's no doubt about it. Comparing the NHS to the West Australian medical system is, particularly at this stage, is not a good habit to get into. We are in a very different scenario, and we do tend to sort of spend a few more resources than the NHS does. Interestingly, we spend more and have less cases, and they spend less but have more cases. But they're at a very different phase in their epidemic or pandemic. What about patients who don't fit the suspect case definition? So if a patient clearly doesn't fit the case definition, then you shouldn't test them. If there's lots of greyness about whether someone does or doesn't, if you're concerned or you want to ask a question, or if you want some advice, or if you want some support not testing them, you can contact an ID physician that's on call now 7 days a week, 9 o'clock or 8 o'clock till 12 o'clock at night. And there's a respiratory physician that's on as well over similar time, and is on call after hours. There's also a microbiologist if you need to, 24 hours a day, 7 days a week. So all of those people would be happy to help give advice, but keep in mind that the person that you're talking to on the phone may not be there. So sometimes it's hard for us to make decisions without seeing the patient, but that we're happy to help you make a decision. If you think that you're going to not swab someone and you just want some support making that decision, give us a call. Happy to talk about it. Hopefully I answered some of your questions. So this is a big one. Why are we not sending COVID swab patients to L2 now? What has changed? Why are we not using the same clean, dirty nurse process in MAU as in L2? What will happen when we start to get COVID positive patients again? So the reason why we're not sending COVID swab patients to L2 now is we've split basically, so over of the 580 cases that have happened in Western Australia, over 2/3 of them have basically been cruise ships. And the remainder, most of them have been either contacts of positive patients, known positive patients, or from overseas. And so basically, we've now re-stratified our patients in the absence of community transmission and in the presence of extremely low prevalence. So we've now got only 6 active cases in Western Australia, and all of them are known about, and all of them are basically in isolation. We don't have any known sort of community transmission occurring. But the reality is that for all of the patients that have no epidemiological risk factors, all of the patients that come in with urties, sore throats, fevers with unexplained causes, those patients have a very, very, very low chance of having COVID-19. So there's firstly there's that re-stratification, and then the other group, which are the patients who are either known positive or they have high epidemiological risk factors. So they've recently returned from overseas, or they've had contact with positive patients, and blah, blah, blah. Those people are still going to go to L2 because they're a higher risk cohort. The patients are the suspect at the moment. are all getting managed the same wherever they are, whether it's MAU or L2. The concept of the clean and dirty nurse process that was occurring in L2 is no longer happening in L2, first of all. And it's a concept that was only really used on positive patients who are proven to be positive. And listen, we will, once a patient is positive, once their swab comes back, that patient will get moved from MAU straight to L2. And that's at any time of the day, whenever that result comes back. As soon as we know about it, we'll get the patient moved to L2. And there's a plan, which is the same plan that was there before, to basically start filling L2, starting with the negative pressure room and swinging around the back of L2 in the areas that have the double doors until we get to the 8 patients, which fills basically the COVID suspect area. And at that point, we will close the rest of L2 down, remove the patients that are there and transfer them to the ward that aren't the routine respiratory patients at the moment. And then we'll go back to the original plan. And at that point, we'd assume that community transmission is occurring, and we'll probably take the suspect patients, which are now higher risk, back to the ward. Now, when you start sort of going, well, what about the clean and dirty nurse if the patient then ends up being positive? The reality is that your standard contact and droplet transmission-based precautions for influenza, that it's no different, and that will provide adequate protection against patients with proven COVID-19. When they're positive, we take a slightly more sort of aggressive infection control approach for obvious reasons. And that's really the difference. And as I said, at the moment we've got very low prevalence. There's very low risk. We're almost a business as usual model at the moment with our patients coming into hospital. And I wouldn't expect much to change until there's a significant demographic change in Western Australia, i.e. the borders close or something like that. And that is the last of the questions. Is there anybody online that wishes to ask a question? They can either pipe up or they can ask a question on the chat and I'll answer it. Got like a minute. Anybody want to ask a question? So if nobody has any questions, then I am going to go. Thanks for listening. Hopefully I answered some of your questions. If there's any other issues or questions, or if you weren't satisfied with my answer, just get in touch with me on the Ramsey email address. I'll be happy to answer your questions further, and we'll go from there. Thanks for your time.